a good afternoon and welcome everyone to our weekly Gecko session hosted by the Gastro Foundation of Sub-Saharan Africa in conjunction with Project ECHO. These are weekly meetings, as many of you are aware, and the recordings are available on the foundation website. This afternoon, we have Bilal Bobat, who's well known to our audience here. He is head of the liver unit and runs the transplant center at the Donald Gordon Hospital here in Johannesburg, a very accomplished clinician and a very good speaker. And Vernon Lowe, our hematologist who runs these sessions, heard this talk at one of the meetings and actually asked him to come and give it here. So Vernon's actually having technical problems, and I'm sure he'll appear soon. So Bilal, great to see you again, and over to you.
Thanks, everyone. And yeah, it's, I suppose, a little bit unusual for me to be on this particular platform. But let me start sharing my talk and just confirm if you can see that.
Yes, we can.
Great. Okay, so I was asked to speak on iron deficiency in gastroenterological and liver diseases. And so to a mixed audience of including hematologists, gastroenterologists, general practitioners, and so on. And this is what I essentially started by, is when you get a when you get a referral, obviously it's important to focus on your history and examination. Is the patient maybe a young female? Anything to suggest possible celiac disease? Always consider the fact that, although the GI is certainly one of the more common sites of blood loss and therefore iron deficiency, don't forget about checking your urine dipstick for urinary sources of blood loss. I know we've picked up a few renal cell carcinomas, even in young patients with iron deficiency that way. I think, one of the biggest things that people are worried about when encountering this is, could it be cancer? It's important to remember that from your scopes, more than half of them are negative for iron deficiency. And obviously there's a number of non-malignant conditions to consider, with celiac disease being found in 3 to 5% of particular population groups that have the specific HLA phenotype. Obviously, in your individuals over the age of 50, your chances of finding a GI malignancy are that much heightened, as you can see in this graph to the right of the screen. But when you're looking at individuals less than 50, then you're certainly looking at a considerably wider differential that you should be looking at. The role of fecal immunotesting, not really recommended as a screening tool. FIT is currently recommended by NICE or NICE for determining whether iron deficiency in an under 60 age group warrants fast track referral. Sensitivities between 83 and 90% for colorectal cancer induced iron deficiency anemia, but then it often misses other pathologies. Remember to look at other causes, and malabsorption being one of them. Malabsorption is possibly one of the more common causes. Poor dietary intake, PPI use. Remember that you need your iron to convert your non-heme iron to heme iron, ferric to ferrous iron, which is then absorbed via the divalent metallotransporter in your enterocyte. And if you are blocking iron, you block that conversion, and therefore you may not get enough in. Interestingly, there was a study looking, I think I'll get to the slide a little bit later, but looking at patients with hemochromatosis. And those on PPIs actually had less phlebotomy requirements than those that were not using PPIs. Iron blockers, such as using zinc therapy for a variety of reasons. I think zinc became very popular during COVID as an almost an immune booster. But remember that it competes for your divalent metallic transporter. So, is your patient possibly using zinc as a supplement? Maybe they should stop that. Other things would include certain, dietary adjustments. Remember that vitamin C would increase absorption, but then your teas, coffees, certain dairy products, these will all block iron absorption. So to inquire about diet there. Again, yeah, so this is the slide that I was referring to, looking at patients, with hereditary hemochromatosis, averaging 3.6 phlebotomies per year before a PPI and down to 0.5 per year after starting a PPI. So, PPIs are really one of the most commonly prescribed medications. And this is where your proton pumps may inhibit iron absorption, and consider deprescribing them where possible. But this bar chart specifically, again, showed patients with hemochromatosis before and after administration of a PPI, showing that your numbers dropped quite considerably regarding phlebotomy. As a gastroenterologist, and I know this forum has been exposed to a considerable amount of Helicobacter pylori education. Remember that our prevalence in Africa is approximately 70%, and you have a 3 times greater risk of developing iron deficiency anemia compared to the Helicobacter pylori negative population. Ideally, diagnose this on biopsy or stool antigen. Look at your local sensitivities for your eradication therapy, and don't forget to confirm clearance 6 weeks later using your stool antigen test, obviously with them being off a PPI for at least a week. Inflammatory bowel disease as a cause, this would be in your younger population group, anemia being the most common of your extraintestinal manifestations. And remember that it is more difficult to treat due to the inflammatory response. Utilize your soluble transferrin receptor with any inflammatory condition, and you probably are looking at a higher serum ferritin to target with these patients, ideally using IV iron preparations. Ongoing iron deficiency anemia can suggest ongoing activity, and remembering that your iron deficiency has a major impact on your patient's well-being. Looking at telangiectasia, these small bowel angiodysplastic lesions can account for anything between 5 and 10% of your GI bleeding. It increases in frequency in your patients as they grow older. Consider it in your cardiac patients with aortic stenosis and Hayes syndrome. And then there was a nice paper that came out in 2023 looking at thalidomide. Looking at thalidomide then as a possible additional agent that could be used to treat angiodysplastic lesions. Other drugs that can be used to treat your telangiectasia include estrogens, which may be difficult to use in your male population. Post-surgical complications, post-bariatric surgery patients, remember that most bariatric surgery would involve cutting out a portion of the stomach, and therefore you can develop a state of relative achlorhydria, again affecting how your ferric to ferrous is going to be converted, and never mind the malabsorptive procedures that cut out the first part of the duodenum where the majority of your iron is actually absorbed. So, your referral to your gastroenterologist, then generally you'd be looking at bidirectional endoscopy. Dual pathology is often found. You can just as easily as have a patient with cirrhosis where you're expecting varices, and you get a varices and a peptic ulcer, or varices and portal gastropathy, or even a portal colopathy, that may be present and account for the iron deficiency. The majority of scopes are still negative, and then you need to consider what your next steps are. Look at your quality indicators. Was it a good quality, both gastroscopy and colonoscopy? Was the mucosa adequately visualized, or was there food debris in the gastric lumen, for instance, or was your bowel prep not adequate? Consider a repeat procedure before moving on to more invasive procedures. Small bowel enteroscopy then allows for visualization of the small bowel, and I know the majority of us that are doing them will do a small bowel capsule, and you may spot a little bit of a red spot. And is it something to be concerned about or not? It's rare that you'll get a big old melanoma or gastrointestinal stromal tumor that shows itself as an etiology. It's often telangiectasia. You can consider lymphoma, melanoma, and then obviously a Meckel's diverticulum. So where you have a patient then with suspected small bowel bleeding, bidirectional endoscopy would be your first option. Obviously, is it occult bleeding? So occult bleeding is where you don't see any you don't know when the patient is actually bleeding, versus overt bleeding, where the patient may very well present with blood in the stool or melena. Get your small bowel capsule at that stage. If it's still negative, you can consider a follow-up wait and see policy. If it recurs, consider a repeat procedure, double balloon endoscopy, or cross-sectional imaging. Double balloon enteroscopy then. There are a few centers that offer this, and it is a very lengthy and laborious procedure, where a particularly long scope with two balloons essentially concertina your small bowel over the scope as it passes through and is able to be examined. Looking at the liver and iron deficiency, so you've got an engorged portal system when you develop portal hypertension. Varices, portal gastropathy are the most common causes, but things such as gastric antral vasculectasia are something else that can occur, especially in your patients with autoimmune liver disease. These patients often have a degree of malabsorption. They're on beta blockers and statins as well, that may contribute to both their intake and whether or not they're able to absorb adequately or not. In these patients, beyond beyond just abnormal gastric bleeding, you also have defective erythropoiesis due to chronic inflammation, folate and B12 deficiency, and then if the etiology is alcohol, then direct alcohol toxicity. You can even get hemolysis with those patients, and that's a syndrome called Zeeves, as you see listed on the screen as an etiology. These patients are often significantly hemodilute, both due to fluid therapy as well as fluid retention from activation of the renin-angiotensin-aldosterone system. Varices, obviously, you can get catastrophic bleeding, and when you have gastric varices, especially, these can be the bleeding here can be quite dramatic. They need urgent care, and a variceal bleed is often an initial decompensating event. Your varices can be graded. As you can see on the left here, I don't really see all too much in terms of gastric varices, but as you progress, you can start appreciating the picture on the right where you can see those red spots or red whale signs on the variceal columns, and you can see just how thick and tortuous they are. If you look at that lesion distally, you can see that it abuts more than a third of the lumen and therefore can be considered large. Portal hypertensive gastropathy is an endoscopic diagnosis. Anything between 20 and 80% of patients with portal hypertension will have a degree of portal hypertensive gastropathy. And not to forget that you will get similar lesions throughout the gastrointestinal tract, including a portal enteropathy and a portal colopathy. It's directly associated to what your hepatic venous wedge pressure is, and is considered a prognostic marker because of that correlation. The worse your portal hypertensive gastropathy, the worse your hepatic venous wedge pressure would be, and therefore the increased chance you have of decompensation. It's thought that the pathophysiology here is associated to increased cardiac output and lower vascular resistance within the splanchnic circulation, as well as local factors such as ischemia and nitric oxide release. Your North Italian Endoscopy Club has come up with a classification of mild, moderate, and severe. Looking at your portal gastropathy, you can see A would be considered mild. You just have relatively diffuse lesions, this crazy paving appearance. B, where you're starting to get these red spots that are occurring, and then severe, where you get a diffusely red areola marking out the gastric mucosa. Portal hypertensive gastropathy versus GAVE then. This is from your clinical manifestations of portal hypertension from A. Said, who came up with one of the classifications. No, that's the Saad Caldwell classification of gastric varices. But here, essentially, you're looking at your differences. Remember, gastric antral vascular ectasia is going to occur in the antrum predominantly, as opposed to portal hypertensive gastropathy, which is more fundal and corpus predominant. And this is a nice picture. If you look at that picture of your portal gastropathy, you can see those red spots within the gastric mucosa being highlighted there. Moving on to looking at hyperferritinaemia, a lot of patients with liver dysfunction are worked up when they have ferritins that are running in the 5, 6, 700s, and you'll see multiple tests being done for hemochromatosis gene panels. Please be aware and be careful of this, because those gene panels are expensive. Just those 3 genes are going to cost the patient 3,500 Rand. And often what happens is that a physician will come along, look at this high ferritin and do a hemochromatotic panel. 2-3 months later, they're still sitting with a high ferritin, and the physician will look at it and go, no, this must be wrong. Repeat the hemochromatotic panel. That's now 7,000 Rand. The patient goes somewhere else. Someone else will repeat. It's the same genes being tested, guys. So don't keep on repeating it. Consider your other causes. And one of the big causes is this concept of metabolic hyperferritinemia, which is common in liver disease. Both alcohol and MASLD have these elevated ferritins. The etiology behind it, and this is the consensus statement published on the 17th of Feb 23 that I'll draw your attention to if you want to go read up more around it. I think it is open access on Nature Reviews. Um, so essentially, it boils down to having an inflammatory response within the liver, resulting in increase in hepcidin, giving you this hemochromatotic state. It's not necessarily true hemochromatosis, but once again, it is associated with inflammation. You have a degree of ferroptosis that occurs within the liver, as well as abnormal lipid synthesis, all resulting in this concept of metabolic hyperferritinemia that occurs. So essentially, these are where you have circulating levels of ferritin greater than 300 in men or 200 in women, plus evidence of fatty liver disease or type 2 diabetes, or any one of your MASLD type MASLD diagnostic criteria. Ferroptosis and ferritinophagy are two important considerations here. Ferroptosis is an iron-dependent regulated cell death that's characterized by increased iron accumulation within the cells, putting in additional reactive oxygenative stress on the cell, resulting then in apoptosis related to the increase in iron. And it's associated then with elevated liver enzymes as well as accelerated fibrosis. Ferritinophagy is somewhat more protective with these patients, and that's been shown to be particularly so in patients with iron deficiency, with HCC, where patients with this imbalance between ferritinophagy and ferroptosis, the patients with more ferritinophagy have better outcomes than those where ferroptosis is predominant. Your liver and anemia in terms of alcohol-associated liver disease, remember that it's not just the action on the liver causing the inflammation, but you'll develop a chronic gastritis. I know at Barrow, when on a Monday, we'd be just filled with scope requests. You go down and you see an inflamed stomach and you ask them, and yes, they had an alcohol binge over the weekend. But in addition, you get folate malabsorption, abnormal lipid distribution, and an increase in your acetaldehyde, resulting in these various forms of anemia, including hemolytic anemia and sideroblastic anemia. Alcohol and iron metabolism then, once again, alcohol will downregulate your hepcidin synthesis, resulting again in your iron blockade. But additionally, your serum ferritin or rather, you get your serum blockade within the liver, resulting in more inflammation. Both chronic and acute alcohol exposure can reduce then your liver hepcidin, and liver exposure, alcohol exposure desensitizes hepcidin transcription to iron levels and resulting in suppression. Care needs to be taken when dealing with your liver and iron deficiency. It requires an accurate diagnosis, and it's important nonetheless, because you're dealing with a portal hypertensive system, to still replace iron when needed. Your patients with your autoimmune liver disease are going to present with fatigue. They're going to present with fatigue. They're going to present with they're going to be needing to prehabilitate and exercise if they have advanced liver disease, so that they can have a successful liver transplant. And this isn't going to be possible if they truly have iron deficiency anemia. At the same time, be aware of this iron blockade, and consider what population your patient is sitting in. Use your additional tests to assess is my patient truly iron deficient? Do I need to supplement iron? And these are patients that are probably going to benefit from IV therapy as opposed to oral therapy in the long run. I think that's my final slide. So let me end my share and open up for questions.
Wonderful. Thanks, Bilal, and thank you, Chris, for opening the session for us earlier. There we go. So let's open the floor for questions. For those listening in, please, you are very welcome to add any comments or questions in the chat. But maybe I can start by asking you, Bilal, just about the fecal immunochemistry tests, because it seems like there's been a lot of development with some of these tests. And can you maybe just share some of your own experience in terms of the advantages, disadvantages, the limitations of those tests? I mean, I've seen figures saying sensitivity is as high as 100%, which sounds very unlikely in some of the publications. But can you tell us a little bit more about where it fits in our paradigm?
Yeah, look, I think there's a lot of hesitancy for patients wanting to or that are willing to proceed to colonoscopy, especially amongst the younger cohort. I think that, you know, a good quality bidirectional endoscopy is probably still preferred. Your fecal tests have improved. You know, they used to just look for any form of hemoglobin. The newer tests are somewhat more sensitive, focusing on specifically human hemoglobin. You know, previously you would have needed to have gone onto a bit of a vegetarian diet because any form of meat would have resulted in a false positive result. Now the tests are somewhat more sensitive, but I think it still really depends on the exact population. My concern about these tests is that they might actually be too sensitive. And you know, you may very well get a little bit of inflammation and result in the next trigger being your colonoscopy anyway. But I think I like them as a tool to overcome hesitancy in having the actual procedure.
Great, thank you. And then the second thing that you just referred to, which is an issue, I think I saw Wayne Simmons in the audience as
Yeah.
well.
Yes.
Is this issue of bidirectional endoscopy, which we feel very strongly about, but we often get confronted, especially in the public sector, by, no, we must first do a gastroscopy and then see if we find anything. Whereas the literature seems to be very clear that there's a high proportion of patients that might have dual pathology in the upper and lower GI area. Do you want to perhaps comment on that?
I fully agree with that. It's not just the public sector; it's the private sector as well, which I think is pushing back a little bit harder on this. And I don't have the exact figures at hand. Wayne, please feel free to jump in and help me out here because I think you've looked into this. But you know, dual pathology is not a unheard of condition when doing these scopes. And I think that, you know, getting a patient in for a second procedure is a little bit more difficult. I think that for iron deficiency, what from you know, my finding is that the medical aids seem to be relatively understanding if that's the indication, and then I think those patients should receive should receive bidirectional endoscopy. And I think that it's also important that cross-sectional imaging also be performed because, like I said, the majority of scopes are still negative, and there is still further pathology that can be accounted for, especially when it comes to renal pathology.
I see Wayne has got his hand up. Wayne, please, you're welcome
Good afternoon.
to get your camera on and speak to us. Thanks.
Let's see. Good afternoon to everyone.
Always nice to
Bilal,
see you.
Thank you very much for a good topic there and a good coverage, especially once you venture into the liver discussion. I think that's very interesting, and I think there's a lot more discussion that we can have there. With regards to this question, I think we recently are in discussion, especially with funders, about screening colonoscopy. And I think the answer will stem from the suspicion of malignancy in a patient. And I think any patient where you suspect a malignancy, and this would be the usual alarms that we would have. Iron deficiency is one of those alarms. Age is another. And there's a debate as to where this age cutoff should be. I think we erred on the side of 45, mentioning that's in our guideline. We recently had deliberation on upper endoscopy, and we arrived at 50. But once you're above that age, certainly, or if you have other alarm features which would suggest that you are suspecting a malignancy, and these we know, I think bidirectional endoscopy should be opted for in the patient with iron deficiency. And I think that's what's clear in our guideline that we've published previously. So I think that's about as clear as I can make that. In the absence of a formal screening program in South Africa for colorectal cancer, if I can point that aspect out on its own, I think we would be doing an injustice to a patient who is at risk for colon cancer to start off with the gastroscopy and then only proceed to colonoscopy if the gastroscopy was normal. I think that approach, which has been used in many settings, is probably lacking for that particular patient. Thank you. Thank you, Prof.
Thanks,
Wayne,
Wayne.
you
That's
want to just
helpful.
comment on your fit testing? Did I manage to cover it in my answer?
Yeah, I think so. Just interestingly, one of our colleagues here is actually looking at colonoscopy versus fit testing in the setting of our unit. And I think she's currently busy with the data collection, and it's trying to address this very question locally. And we look forward to what she says. I think we need to look at local data, and I think the figures are overtly, it appears overtly sensitive in the studies that I've read, and I think I would err on the side of our guideline because we've discussed it quite extensively and resolved that any patient, and the other way to look at it, any patient requiring the fit test, one should ask yourself the question, what is the indication for that fit test? And is that indication not an indication for endoscopy in the patient, which in our setting, I think what is clear in the guideline is that these non-invasive tests have their role in colon cancer screening guidelines. That's where they're structured and that's where they are employed. And I think in a country where we don't have such a screening program, official screening program, one should be careful to utilize these tests in patients and hope that we're doing them safely in our population as well without robust data, which I'm looking forward to our colleagues' information and see what she finds. And if there's a correlation, we can start to look at it further here. Thank you.
When we book you for a presentation on that once that's available, you or your colleague or both?
Well,
that sounds good.
I think that would be good.
For the benefit of the audience, Wayne was the lead on the guidance document on iron deficiency in gastroenterology. I've put the link in the chat, so you can download it for free from the journal website. So that's great. The other thing I would like to add is, because I see many people in the audience that I know from experience have a particular interest in iron deficiency. But what you'll find is that once you start to build up a practice of patients with iron deficiency, you'll start to get a lot of referrals also for patients with high ferritins or iron overload. And it's so important to recognize what Bilal has talked about with the metabolic hyperferritinemia. Because in my experience, that's far more common than hemochromatosis, even though hemochromatosis is the most common, one of the most common, if not the most common, inherited genetic disorder amongst Caucasians in South Africa. Not nearly as common as in Europe, but still very common here. So very important, and I think the transferrin saturation is the clue. If the transferrin saturation is on the lower side, less than 40%, less than 45%, with a high ferritin in a patient with a typical phenotype of metabolic syndrome, that's when I would not usually go to hemochromatosis testing. But Chris, maybe you and Bilal can give your opinion on that.
Yeah, I would agree. I mean, it's a very common issue with metabolic syndrome. We don't see it in other liver diseases, interestingly enough. So it's I think it's the insulin resistance and the metabolic syndrome that contributes to it. Look, I screen ferritin. I've seen genetic hemochromatosis with very low ferritins.
But that is true.
Yes.
I'm talking more about the transferrin
Yeah.
saturation.
Yeah, but the transferrin saturations were high in that situation. So I agree with you. I think you've got to use both. And I've yet to, I think, in the metabolic hyperferritinemia milieu, I think I've yet to find a positive genetic screen. The question is whether we should venisect these patients, and whether the metabolic hyperferritinemia is contributing to that fibrosis below.
So I think it is contributing to the fibrosis, but the studies on venesection in MASLD have actually been negative thus far. It just makes you a bit more anemic. It doesn't really help with that. I think this is a particularly liver focused process as opposed to a systemic process. And then Prof. Lowe, to answer regarding the iron sats, I think that's certainly true for your MASLD phenotype. But when you start adding the MET-ALD and your more alcohol predominant phenotypes, there you can actually have percent sats in excess of 50%. And it's effectively a similar mechanism to what the hemochromatosis is doing, but almost a secondary hemochromatosis type pattern develop. The thing is that you don't necessarily get your ferritins as high as your true hemochromatotics. You don't get those 4,000 and 5,000 ferritins. You're often sitting in the low hundreds or just above 1,000 at most. But again, it is one of the features that I look at in terms of just how much alcohol is this patient drinking. It's fairly tied to that amount.
100%, and it makes complete sense because in the alcohol derived situation, it's actually increased iron absorption because their hepcidin is low. So they tend to absorb more, so your transferrin saturation is going to be high. I must say, from my perspective, I'm not actually surprised that venesection doesn't work in MASLD, and I'll tell you why. So ferritin itself is supposed to be pretty inert and not cause damage. It's the labile plasma ion, which is non-transferrin bound, that cause the problems. And that typically starts to be released when your saturation, okay, let's say this, you find significant amounts when the saturation is between 60 and 70% or higher. And if I say that, I'm specific, it's very important to note this is in patients who are with a fasting transferrin saturation. Someone who's taking iron tablets can easily have a saturation of 80, 90%. So be careful. You can misinterpret, and I see it very often. Some studies have shown that even around 50% saturation you can have some non-transferrin bound iron. And that's the component which in the plasma starts to bind to all kinds of proteins and also to cellular membranes, but that can also be taken up by the cell and then form reactive oxygen species inside the cell, causing a pool of what we call labile cellular iron, and that causes the damage. Whereas, surprisingly, and this is still something very interesting to me, although ferritin in the circulation can carry iron, and there's even something called ferritin saturation, believe it or not, generally speaking, there's not a lot of iron in the ferritin. It seems to be correlated with the stores, but if not with the stores, then it's either an acute phase protein or released from liver cell damage. But the ferritin itself, from my understanding at least, and please correct me if I'm wrong, is that ferritin is not nearly, well, is not even generally considered to be a toxic substance.
Yeah. Yeah, that makes sense. Absolutely.
Which would explain why the venesections wouldn't work in MASLD, I think, because you don't have that free iron. Because with venesections in hemochromatosis, you're really trying to get rid of the free iron and move it to red cell production by straining the marrow, getting blood out. That needs to be replaced. The iron moves to the marrow, and hopefully out of the organs as well with time. So definitely a lot of thought-provoking things here.
Yeah.
What I liked about your talk, Bilal, specifically, where I think you bring in a new angle that none of us have ever really addressed properly, is the whole issue around the liver, portal hypertension, GAV, all those things. I recently saw a patient with GAV. Hematologists don't see those things very often. So for you guys, this is your second nature, but I really think you bring in a very interesting perspective on some causes of iron deficiency that's not front of mind for us, generally speaking. And it really struck me at the Anemia Day meeting when you spoke about it. So, oh my goodness, I need to go in deep, do a little bit more of a deep dive. So even though I heard this talk now for a second time, I thoroughly enjoyed it. And I, again, learned things that I probably didn't concentrate well enough the first time. So I'm so happy that I could listen to this twice. So I want to say a big thank you to you for making the time to prepare and to come to us and to speak to us. And thank you also to everybody in the audience that joined us. It's really great that you could come. I think I'm going to close in the absence of any further questions and just say a big thank you also to the ECHO group in University of New Mexico and the ECHO India teams that help us every time to with the logistics of these meetings and the technical stuff at the background, for Cheryl Valentine, who's a very consistent, always there person to help us make it work, for Chris, as the lead person, the pioneer, and the one that's the energy behind the GECHO and Gastro Foundation. Also thanks to the Gastro Foundation specifically. Again, a reminder, as Chris mentioned in the beginning, all the talks here, and there's lots of historical talks from PBM. We have a talk like this now for a few years already. Chris, I don't know when we started, but it must be about 3 or 4 years, I would imagine. Many, many PBM talks that you can go back to. And next week will be lower endoscopy, for those who would be interested to learn more about that. Please join us and join the group.
Yeah.
And with that, I close the meeting and say, wish you all a wonderful evening.
Thanks so much,
Thank
Prof,
you again, Bilal,
for having me. And I just want to say, go Congo and go Senegal.
Mm.
Go play tonight.
Good night.
Yes.
Cheers,
Have a
everyone.
good leave,
Okay.
Vernon. Thank you, Cheryl. Thanks, everyone.
Bye-bye.
Thank you.
Right,
Bye-bye.
cheers then.
Bye-bye.
Bye.
Bye.